Okay, so we will start right away. My name is Dami Famutimi. I work with Amr'S. I'm a brand manager, and it's great to have everyone on this call. I know that at the end of today's call, we would have learned, relearned, and unlearned as touching antimicrobial resistance and best practices to ensure that we keep our patients and even ourselves safe as the rise increases, and also to all right. We are delighted to have with us today to be a facilitator for today, Professor Oyin Oduyebo. And I would read a citation after which she would take us through today's webinar. Professor Oyinlola Oduyebo, Professor of Clinical Microbiology, MEBS 1986, MSc Medical Microbiology 1995, FWACP Lab Med 1998, FMC Path 1998, MD 2021, FRC Path 2023. She's a lecturer in the College of Medicine of the University of Lagos, and she has been a lecturer since 1998, teaching medical microbiology to medical students, postgraduate students, nurses, and midwives. Also a honorary consultant to the Lagos University Teaching Hospital, helping to manage the hospital laboratory, investigating and managing healthcare associated infections, and training resident doctors. Research interests have been around antibiotic stewardship, antimicrobial resistance, and healthcare associated infections. The results of our research have helped to educate healthcare workers on rational antibiotic use and importance of adequate infection control practices. The results Currently, she's the chairman of the Antimicrobial Stewardship Program and also of the Infection Control Program of the Lagos University Teaching Hospital, a member of the AMR Technical Working Group in Nigeria, in collaboration with the British Society for Antimicrobial Chemotherapy and the Infection Control African Network. She led the development of a 3 week Future Learn MOOC training, Antimicrobial Stewardship for Africa. She is the national coordinator of the National Antimicrobial Stewardship Working Group in Nigeria, an arm of the Clinical Microbiology and Infectious Diseases Society of Nigeria, CLIMIDSIN. Let's make welcome our speaker for today, Professor Oyinlola Oduyebo.
Thank you very much for the kind introduction. I hope you can all hear me.
Yes, ma'am, we can hear you loud and clear.
Thank you very much. Yes, we are going to talk about antimicrobial resistance, united strategies to curb the rise and spread of antimicrobial resistance. And we will be I'll be talking through this outline here. I would introduce the subject. I will tell us about the definition and implications of antimicrobial resistance. We'll talk about the causes and mechanisms and the key drivers of AMR. And then we will talk about the solutions to this problem. You know, there's a critical global health, as well as antimicrobial stewardship, which is our area of influence. Antimicrobial resistance is a critical problem. It is a global health threat. It increases healthcare burdens, it imposes economic costs, and contributes heavily to death rates. And worse, it threatens to return us to the post-antibiotic era, the speculated post-antibiotic era. Remember that era in life where there were no antibiotics and people were dying from simple infections like wound infections. Strategies have been recommended to slow down the trend of AMR. But for us to understand these strategies and how to use them so that we can effectively combat the threat of AMR, we need to understand the mechanism and the drivers. Antimicrobial resistance is the ability of a microbe to resist the effects of the medication that once could successfully treat the microbe. The resistant microbes are more difficult to treat. They require alternative medications or higher doses, which may be more expensive or more toxic or both. And when we say antimicrobials, we're saying antibacterial, antifungal, antiviral, antiparasitic. And antimicrobial resistance will mean resistance to these various groups of microbes. And so the term antibiotic resistance is a subset of AMR. It applies to bacteria becoming resistant to antibiotics. Antibiotic resistance can be intrinsic or acquired. Intrinsic resistance being conferred by resistance genes, including genes associated with efflux pumps and other mechanisms. Such genes are present on the chromosomes of the bacteria, and they're shared by members of the same species or genus. Acquired resistance, on the other hand, is conferred newly by new resistance genes. New resistance genes gained via horizontal transfer or mutation of particular chromosomal genes. And generally, horizontally transferred resistance genes are located on mobile genetic elements, plasmids, transposons, and this can be defined as any segment of DNA that can translocate from one part of the genome to another. Some of them we call jumping genes. They can be transferred from microbe to microbe, from bacteria to bacteria, to the same type of bacteria, to related bacteria, or to other bacteria. And generally, this transferred resistance is the one, this transferable resistance, this acquired resistance is the type that we're more worried about. Acquired resistance is a natural biological phenomenon. It will ultimately occur, but it can be accelerated by a variety of factors, including human factors. The use of an antibiotic forces the bacterium to either adapt or die, and this we call selective pressure. When an antibiotic is used to treat a typical bacterial infection, most bacteria are killed, but sometimes some of the bacterial strains may have an advantage, meaning they have resistance gene. So they are not killed, they live on. In some cases, the bacterium will survive antibiotic treatment and then multiply. The remaining resistance one, because they have genes to multiply. And bacteria can undergo mutation. It can be intrinsically resistant. And such bacteria can then reproduce and pass on the advantage of the gene, creating many more antibiotic resistant bacteria. Widespread antibiotic use can make more bacteria resistant through the process of evolutionary pressure. We're talking about natural occurrence, used in veterinary medicine, water pollution, clinical use. Genes for resistance to some antibiotics are ancient. They often predate antibiotic use. For example, in 1952, it was shown that penicillin-resistant bacteria existed even before penicillin treatment, even before it was used. Also, pre-existent bacterial resistance to streptomycin was documented. Klebsiella is known to be naturally resistant to ampicillin, and Proteus is naturally resistant to colistin. These genes may be transferred from non-disease causing bacteria to those that cause disease, leading to clinically significant antibiotic resistance. All animals carry bacteria in their intestines. Antibiotics are given to animals as growth promoters. These antibiotics will kill most bacteria, but resistant ones will survive and multiply. And studies have shown that inappropriate use of antibiotics in animal husbandry is an underlying contributor to the emergence and spread of antibiotic-resistant bacteria. Antibiotics have been polluting the environment since their introduction through human waste, animal waste, and the pharmaceutical industry. The contribution of the pharmaceutical industry is so significant that parallels have been drawn between countries with the highest rate of increasing antibiotic resistance and countries with the largest footprints of pharmaceutical industry. Now, clinical use. This is the part that concerns you and I most. Bacteria will adapt. They would rather be adapted than be killed when we use antibiotics incorrectly. When you use them for a too short duration, the dose is too low, the potency inadequate, or when we use them for the wrong disease, they will, rather than killed or be killed completely, they will multiply. Such microbes will adapt and survive and carry genes for resistance, which can be passed on. And paradoxically, underuse may play as important a role as overuse. Use of beta-lactam antibiotics has been implicated. The overuse of beta-lactam antibiotics, such as penicillins and cephalosporins, have been implicated as a risk factor for infection and colonization with penicillin-resistant Streptococcus pneumoniae. Overuse of broad-spectrum antibiotics, such as the second and third generation of cephalosporins, greatly hastens the development of methicillin resistance in Staphylococcus aureus. And today we have various resistance problems that have been defined. There is the ESBL producing gram-negative bacteria. ESBL stands for extended spectrum beta-lactamase. This is an enzyme produced by gram-negative bacteria that hydrolyze the third generation cephalosporins, like ceftriaxone that we love so much, like cefotaxime, ceftazidime. This the ESBL hydrolyzes them. And when you have resistance to this third generation cephalosporins caused by production of ESBL, the next antibiotic of choice is the carbapenem, meropenem, imipenem. That's what we use, to combat ESBL producing gram-negative bacteria. But carbapenem resistance has also been on the increase. They have been increasing steadily. There's AMC-mediated gram-negative resistance. We have multi-drug resistant Klebsiella pneumoniae, MDR Staphylococcus aureus, especially Amr'S, the methicillin-resistant Staphylococcus aureus. These days, we have various resistance problems or patterns that are problematic. Why is this important? What's the importance of clinically significant resistance? Bacteria are particularly efficient at enhancing the effects of resistance because of their ability to multiply very rapidly. and because they can transfer resistance genes, which are passed on when they replicate. In the medical setting, such microbes will not be killed by a standard course of antibiotic treatments. The resistant bacteria can also pass on their resistant genes to other related bacteria through conjugation. And this resistance to a single drug can spread rapidly through a bacterial population. The hospitals are known to be a critical component of antimicrobial resistance problem worldwide. Why is this? The hospitals are the sites of treatment for patients with infections, patients with severe infections, patients with ailments that are not infections, who bring their normal flora to the hospital. So failure to implement simple infection control practices and procedures is a common cause of infection spread in hospitals. And this is a global problem. It's not just the third world country. Cross-infection, will result in transmission of hospital pathogens to highly susceptible patients. So in the hospitals, we have the combination of highly susceptible patients, intensive and prolonged antibiotic use. We have cross-infection resulting in nosocomial infections with highly resistant bacterial pathogens. So then, in summary, what are the key drivers of antimicrobial resistance? We have antimicrobial genes being widely distributed in bacterial populations, enabling resistance through adaptations. We have mobile genetic elements acting as carriers, like plasmids acting as carriers for antimicrobial resistance genes, facilitating horizontal spread to related and unrelated bacteria. We have accumulation of antibiotic residues in the environment, which enhance bacterial resistance. We have increased cross-resistance to disinfections and antimicrobials. We have significant antibiotic use in livestock, which amplify antimicrobial residues and resistant bacteria. Antimicrobial residues in animal-derived products, manual fertilization, spreading AMR to soil and crops. These are compounded by weak healthcare systems and animal-human environment interactions. We have contaminated food and environment, which increases human exposure to resistant bacteria. And we have widespread substandard and falsified antimicrobials, which create subtherapeutic selection pressure. We have inappropriate prescribing and cross-infection in hospitals, which drive AMR transmission. Community and antimicrobial misuse and irrational prescribing practices drive AMR. And then we have widespread antimicrobial misuse and weak regulatory policies. What this tells us is that our strategies have to incorporate appropriate controls in human health, in animal health, and the environment. So what has been the global response to this? The Nigerian National Action for AMR, the Nigerian National Action Plan for AMR is in line and in tune with the Global Action Plan by WHO. The first version of the Nigeria National Action Plan was launched in 2017. It was a 5-year plan, and it was revised and updated in 2024. The version 2 was launched in November 2024. It is based on One Health approach, and it aims to reduce and prevent and slow down the evolution of resistant organisms. and their impact in humans, in animals, and the ecosystem. It utilizes it details 6 strategic objectives and include appropriate strategic interventions for each of the objectives. Now, objective 1 is to strengthen leadership, collaboration, coordination, and AMR governance structures at national and subnational levels. The first version does not include, it didn't include this objective 1. We had 5 strategic objectives in the first version, but the updated version, the version 2, has 6 objectives, which includes this objective 1. Now, objective 2 is to improve antimicrobial resistance. Objective 2 is to improve AMR awareness, education, understanding, and behavior change among all relevant stakeholders. Objective 3 is to improve evidence base through strengthening One Health AMR surveillance system and operational research for decision making. Objective 4 is to improve implementation of infection prevention and control programs, biosecurity and vaccination uptake, including access to WASH. WASH stands for water sanitation and health, across the One Health sectors. Now, objective 5 is to improve access to quality antimicrobials and optimize their use across One Health sectors. Objective 6 is to build knowledge and capacity of relevant stakeholders to improve local innovations, research and development in antimicrobial diagnostics and vaccine. Now, our focus, should be objective 5, which is to improve access to quality antimicrobials and optimize their use in human health. Now, let us focus on the strategic interventions, for this objective 5. There are 5 strategic interventions, though the first 3 concern us. One is to improve implementation of antimicrobial stewardship policies and antibiotic guidelines across all sectors and enforce their regulation. The second one is to gather data for antimicrobial stewardship. And the third is to ensure access to diagnostics, infrastructure, and quality antimicrobials. Now, how do these 3 concern us? Well, to improve implementation of stewardship policies and guidelines in human health means that every hospital, whether it's a primary healthcare center, secondary care, tertiary healthcare, whether it is public or private, has to have antimicrobial stewardship strategies. Stewardship policies, we have to have antibiotic policies and guidelines. We have to update them from time to time, and we have to make sure that we utilize them so that this affects our practices. And that way, we can actually have influence on how we use antibiotics so that we can slow down, the spread of AMR. Now, we're to gather information on antimicrobial stewardship. It means that before we start antimicrobial stewardship, we first have baseline information. What are prescribing practices like? What is the pattern of antimicrobial consumption? Do we have antibiotic guidelines? How often do we use our laboratory? This is diagnostic stewardship. As we gather data, we need to gather data on monitoring and evaluation, which means what is the impact of our programs. And then we need to ensure access to diagnostics. This is where we really fail woefully. We have laboratories, at least in the in all the tertiary centers and maybe in some general hospitals, we have laboratories, some of them up-to-date laboratories, but we fail to use them. And I'm not just talking common sense. Data have shown that targeted treatment is less than 10%. Targeted treatment therapy, meaning antibiotic therapy, antibiotic prescription based on laboratory information, is less than 10%. This just tells us in a simple way that we do not use laboratories. And then quality antimicrobials. There's a lot of falsified and substandard antibiotics. I'm told, that we have doctors in the audience, we have pharmacists in the audience, and when I'm talking about quality antibiotics, I'm speaking straight directly to the pharmacist. What roles are we playing to ensure that antimicrobials are of a high quality? How are we trying? What are we doing, to avoid substandard and falsified antibiotics? And what really do we mean by antimicrobial stewardship? It is defined as coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of optimal antimicrobial drug regimens, including dosing, duration of therapy, and route of administration, thus preventing harm to the patients and preserving drugs for future patients. The first thing we have to recognize, by this definition, is that antimicrobial stewardship is a formal program. It is not what I'm doing in my consulting room, or what we are doing in our own laboratory, or what the pharmacy is doing in their pharmacies. It is not. It is a program, that brings all of us together. It is what we are doing together, to ensure, that we are using antimicrobials judiciously. What is the goal? The main goal is to monitor and manage the antimicrobial use, by optimizing antimicrobial therapy, by reducing treatment-related costs, by minimizing adverse events, and ultimately decreasing the risk of development of antimicrobial resistance. There are many tactics, which are core strategies and supplemental strategies. There are two core strategies, which are evidence-based and which are proactive. These include formulary restriction and pre-authorization and prospective audit with intervention and feedback. The supplemental strategies include education, guidelines and clinical pathways, antimicrobial order forms, streamlining or de-escalation, dose optimization, intravenous to oral therapy, intravenous to oral switch, antimicrobial cycling. And all this, although we cannot avoid the use of combination therapy, it is generally not recommended. So our supplemental strategy, especially when we're starting out, may be that we avoid as much as possible the use of antibiotic combinations. What do we mean by formulary restriction and pre-authorization? This strategy involves limiting the use of specified antimicrobials to certain approved indications. It involves an antimicrobial committee creating guidelines pertaining to the approved use of these agents, and there must be designated personnel made available for the approval process. In simple terms, it means, that if as a doctor, I prescribe an antibiotic for a patient, the antimicrobial stewardship team or committee will look at my prescription. They will look at it and see whether it is in line with the antibiotic guidelines of our institution. If it is in line with it, there's no problem. If it is not in line with it, then there's no approval. I will be advised, to consult the guideline and prescribe appropriately. This strategy leads to direct control over antimicrobial use at an institution and educational opportunities for prescribers when a request is made. I'm sure we are all aware of the WHO Aware classification, which was developed for evaluation and monitoring of antibiotic use. It classifies antibiotics into different groups, three: the access, watch, and reserve. And this classification is to emphasize the importance of their appropriate use. This classification is intended to be used as a tool for countries to better support antibiotic monitoring and stewardship activities. The access group includes antibiotics that have activity against a wide range of commonly encountered susceptible pathogens. They have lower resistance potential than antibiotics in the other groups. Most are recommended as essential first or second choice empiric therapy treatment options for infectious syndromes. Then there's the watch group. This includes antibiotic classes that have higher resistance potential. So they are recommended for prioritization as key pathogens of stewardship programs and monitoring. Some of them are recommended as essential first or second choice and treatment options for a limited number of infectious syndromes. And there is the reserve group, which includes antibiotics and antibiotic classes that should be reserved for treatment of multi-drug resistant organisms, whether confirmed or suspected. The reserve group antibiotics should be treated as last resort options. These antibiotics should be accessible, but their use should be tailored to highly specific patients and settings when all alternatives are failed or are not suitable. These medicines could be protected and prioritized as key targets of national and international stewardship programs involving monitoring and utilization reporting to preserve their effectiveness. This list is not as long as the whole list of antibiotics, but it just shows most of the antibiotics that are available in Nigeria as of today. We have a lot of antibiotics that are not available to us in Nigeria that have been classified as well. We can see from this list, that the longest is the access group and the shortest is the reserve group. And we can look at them to see which ones we use, which ones we prescribe most often. The access group, is the list that we should be prescribing most often from, followed by the watch group and the reserve group. I had the opportunity of a list of most of the antibiotics, that are marketed by Amr'S. And I have a question for Amr'S. You have some antibiotics that you market some antibiotics that are in the access group and some in the watch group. Are you aware of the resistance profile or the sensitivity profiles of these antibiotics? Because WHO recommends, that we should prescribe the more than 60% of the antibiotics that we prescribe should be from the access group. That assumes, that all these antibiotics should be active for us to use. Have we found it? Have we found them active? Amr'S, these are your antibiotics, which are access antibiotics, as active as they should be. Then the watch antibiotics, how active are they? And really, ultimately, is this classification, aware classification for our use by WHO really feasible? So the summary of formulary restriction is that we prescribe antibiotics before the antibiotic is taken, or before it is purchased, before it is bought by or collected by patients. There must be an approval process in line with antibiotic guidelines, and that is assuming that we even have guidelines in the first place. And formulary restriction indeed should apply to those antibiotics in the watch and reserve list. Those in the watch list, that have higher resistance potential, the resistance develops to them very easily, much more easily than the access group. And this watch group includes most of the highest priority agents that are relatively at high risk of selection of bacterial resistance. Now, the reserve, should have actually for treatment of confirmed or suspected infections caused by multi-drug resistant organisms. So I hope you agree with me, that those in this list should be the ones for formulary restriction. There are challenges of formulary restriction, which have been documented. One is that prescribers can have a perceived loss of autonomy when making clinical decisions. They're supposed to be in charge of their patients, and they take responsibility, and they are completely right. Another challenge is that the formulary restriction may be time-consuming, and personnel may need to be available for consultation at all times. And there is this high startup cost to implement and monitor the effectiveness of such a program. Now, the second core strategy is prospective audit with intervention and feedback. And how is this different from formulary restriction? It means that for a prospective audit means that you have prescribed the antibiotic, the patient is already taking it, but the antibiotic is audited. So you can go through your wards and identify all the patients, that have been prescribed antibiotics and that are indeed already taking them. You audit based on your institutional antibiotic guidelines. The ones, the ones that are not in line with the guidelines are considered inappropriate. And then you intervene here and advise the prescriber to use alternative and agents that are in line, with the hospital guidelines. So prospective audit with intervention and feedback involves a daily review of targeted agents' appropriateness. A follow-up intervention may involve contacting the prescriber to recommend alternative agents, and it may require an antimicrobial committee to develop guidelines for appropriate use of targeted agents. Personnel are needed to perform the reviews and follow-up communication on a daily basis. The advantages of prospective audit within intervention and feedback is that prescribers may not experience a loss of autonomy, may not perceive loss of autonomy, especially if suggested changes by the reviewers are voluntary. And it allows opportunity for educating prescribers through follow-up. We have experience in those with a prospective audit and intervention because this is what we use. When we first decided, when we first chose prospective audits, as our strategy in those, we realized, that we have challenges mainly manpower. Who would do it? And the doctor said, they were not going to. The pharmacists, declared that they had shortage of manpower. They were already overused. And we were forced to look inwards. We had medical students that come for rotation periodically. And then we decided, that in addition to the students, relieving the consultants of this duty, they could be doing the audit, to prepare them as well for clinical practice. And we conducted a study, to determine whether the medical students on rotation were actually able and capable, of performing this audit. They were 500 level students. And we were able to demonstrate, that they could do it. And based on the results, we published this paper in 2018. And following this, we confidently started doing a prospective audit in North. And for 6 months, we reviewed all our antibiotic prescriptions on a daily basis. We reviewed 1,146 antimicrobial therapies prescribed, for 582 patients. And we judged compliance with departmental guidelines. Compliance was found to be 59.3%, and prescriptions were judged inappropriate in 40.7% of therapies. And based on the antibiotic guidelines, prescribers of inappropriate antibiotics were contacted with the recommendations of the reviewers. And these were the interventions performed based on the type of inappropriate prescription, that we found. They were advised for 234 prescriptions they were advised to change therapy. In 125 cases, they were advised to stop antibiotics. In 94 cases, the advice was to reduce to fewer antibiotics. In 7 cases, the intervention was to change dosage, to reduce duration in 8 cases, and to de-escalate. And what we did, with compliance or non-compliance with these recommendations was important. It was important, because it could help us, to educate the prescribers and also to update, guidelines based on the opinions and lessons learned, from the interventions. And we're able to see, that in 100 cases, the prescribers were compliant, when they were told, in 100% of cases, meaning in all cases, when they were told to de-escalate, they complied. But when they were told to stop antibiotics, only 32% complied. We then plotted over 6 months the trends in compliance with departmental antimicrobial guidelines and the stewardship recommendations. And we found, rate of compliance with the guidelines, which is in red, to increase from 42% steadily to 72%. And in case of compliance with interventions, the rate was 35% in the first month, but it increased steadily to 54% after 6 months. And we're able to conclude, that the use of prospective audit and with intervention and feedback improved antibiotic use in a hospital, although we noted more work to be done to improve the lapses noted. And our findings were statistically significant, and we were able to encourage all other departments. We did this in our pediatrics department. We're able to encourage all other departments and health institutions around to embrace prospective audits, because we proved that it worked. Education is a very important supplemental strategy, and that's what we're doing here as well. We recognize it as important. It is important because antimicrobial stewardship is a behavior change program needed to disperse information in an accurate and timely fashion. It is actually required if you want your stewardship program to succeed. But then there are other supplemental strategies. The use of guidelines and flowcharts, streamlining or de-escalation, they are the same thing. Dose optimization, IV to per oral switch therapy. These are strategies that were taught in school and which is assumed, that we use all the time. But surveys of hospitals have found that these practices are frequently inadequate and they're not routinely implemented. So what does this mean? That the core strategies are important and we should aim to use them. Whatever program or project you use, monitoring and evaluation is very important. So for your antimicrobial stewardship, it is important to evaluate at two levels. You evaluate your program, process measures, and you also evaluate the impact on the outcome. And for process measures, you want to know whether your intervention, whether it's prospective audit with intervention and feedback, whether it's formulary restriction, or whether it is just education. You want to know whether it results in the desired change in antimicrobial use. In other words, is it really feasible in your hospital? Global PPS, helps you to do a survey of prescribing patterns and quality indicators, and it's easily used, to evaluate your program. There are quality indicators, many that you can use. Global PPS stands for Global Point Prevalence Survey of Antimicrobial Prescribing and Resistance. We also can do audits. Your audit finding, remember prospective audit, that I talked about. It can help us, to evaluate the process. Now, the outcome measures. What you want to know is whether your process, whether your program or the process implemented has reduced or prevented AMR, whether it has resulted in reduced mortality, whether it has resulted in reduction of adverse effects of antimicrobials. And how do you do this? You look at, it means that you do and you continue to monitor your AMR rates, your resistance rates, you monitor mortality rates, you can monitor length of stay in the hospital. The challenge here, is that it is not really easy to do all these outcome measures manually when you do not have electronic medical records. And as we do antimicrobial stewardship, and I can tell you this from experience, you should expect barriers. Now, what barriers should you expect? You have uh, the appropriate personnel may not be willing to devote extra time and efforts required towards developing the antimicrobial stewardship program and enforcing them. This may be underlined, by manpower shortage, which is a general problem in everywhere in Nigeria. And then there's the resistance to change. The average doctor wants to continue to prescribe the way he wants to, because the problem of resistance is not really in his face. Apart from that, it's a future problem, but any responsible doctor really, or an average, let me say average responsible doctor, will want to consider only the patient that is before him right now. What does he need to do to make sure that that patient gets better? So it is rather slow to change his behavior. Change is something, is always a difficult thing to achieve. And another barrier is that the stewardship team members may not want to antagonize colleagues in other specialties, because they do not want to damage relationships. Then there's the perceived loss of physician autonomy pertaining to clinical decision making in some cases. Also, there's shortage of infectious disease trained pharmacists, and this can be a problem. There are the restriction policies you may come up with may be rather challenging, to adopt. And then there's a continued need to assess the success of a program in order to sustain efforts. This may be taxing. But I can also tell you from experience, that all these barriers can be addressed with appropriate education. There's nothing like confronting colleagues with data. Nobody argues with data. So this is why we need to gather data all the time and confront our colleagues with it so that we can win more and carry more people along with time. So how do you start an antimicrobial stewardship program? The first thing is that you obtain relevant baseline information on antimicrobial prescribing and use in your healthcare facilities. Global PPS may help to do this. A global point prevalence of antimicrobial stewardship, antimicrobial prescribing and resistance. This is a tool that is simple, it is standardized, and it is freely available. It is web-based. It's a web-based surveillance tool. It enables assessment of quality of antibiotic use and identification of targets for improvement. Data must be disseminated and available. Evidence must be the basis of local AMS action plan. You see, we have a lot of data, lot of publications based on global PPS. There are many all over Nigeria, but my observation personally, it is that it has not resulted in a change in prescribing. It is not enough to publish. We must use these publications to in such a way that it will result in a change in our actions. And then we need to make advocacy visits, to facility management for support and protected time for AMS interventions and activities. Whether we like it or not, it is extra work. And just as we run clinics, we do ward rounds, we do surgery, and we allocate time to them, we must also allocate time to antimicrobial stewardship. You perform a SWOT analysis in your institution to determine readiness and write out an action plan for the program and pursue it. And then you ensure appropriate oversight and governance to ensure proper implementation, monitoring, and sustainability. And who should be responsible for the program? You need to have an antimicrobial stewardship committee in your facility. Your committee and or team, depending on the size of your facility, should be multidisciplinary. You require interprofessional efforts across the continuum of care. You can see, that here we need the IPC practitioner, AMS champions, microbiologist, the nurse, the pharmacist, clinician, epidemiologist or statistician, IT specialist, and your patients' voices would also matter. This is the minimum requirement, for a committee or team. Members, you must have well-defined responsibilities, but it's been documented, that you require a passionate leader who is knowledgeable and experienced, and there must be a multidisciplinary approach. ID physician, clinical microbiologist with ID training, the clinical pharmacist with ID training, clinical microbiologist, all this, should be in your committee. Hospital epidemiologist, infection control specialist, IT specialist. This is the very minimum, that you need to, to have an effective stewardship committee. And your stewardship committee must perform their action based on policies and guidelines. Your hospital or facility must have policies and guidelines for operations. This, when you don't have guidelines or policies, you can adopt, the national policy and guidelines. Nigeria has, although this has to be domesticated. Let me leave you with a useful resource. The NASWOG, has published a guidance document for antimicrobial stewardship. And it emphasizes, that your antimicrobial stewardship program is as good as your committee. It was published, you can, in 2023, and you can always access it. I'd like to thank Amr'S for inviting me, Amr'S Pharmaceuticals, for inviting me to give this talk, and everybody for listening. Thank you very much.
Thank you so much, ma. Thank you so much, Professor Odu. Let's keep our reactions coming in. Thank you, ma. That was very insightful. Thank you so much, ma. But do we have any questions? We can use the Q&A tool or send it via the chat. Any questions or comments? Yabari Asa, I can see that your hand is raised. Please, can you type your question in the chat? Amma, you can stop sharing your screen.
Okay.
Thank you, ma. Okay. Kindly send your questions to the chat or use the Q&A box. So I have a question here. This is from Ajake Lawal. She says, "Good afternoon. Aside from not abusing antibiotics, are there other prevention methods to ensure and prevent antibiotics resistance? Aside from not abusing antibiotics, are there other prevention methods to ensure and prevent antibiotics resistance?"
I go ahead and answer.
Yes, ma, you can.
Yes, there are other methods, and I spent a long time talking, about um, the how resistance occurs and what NCDC has done over time. Yes, there are many, and I've spent the last 1 hour, talking about them. And looking through the presentation, you can recollect, all the things I have said. But I must ask whether you mean methods outside your own area of influence. Hello, I hope what I'm saying is making sense to you. Do you mean methods outside the ones I have talked about? Because I have spent time talking about many
Okay, I
measures.
think she meant methods outside the ones that you mentioned.
Well, I have I don't know if you know about any, you can share with us and we can talk about them.
Okay, we have another question here. What is one practical behavior change that communities can implement immediately to help reduce antibiotic misuse?
Education. That's one practical thing. It is education, because they have to know what the problem is first. They have to understand the problem, and they themselves can even come up, with ways that you can change. For example, you can tell patients, stop buying your drugs in the open market, because that's where you're exposing yourself, to substandard and falsified antibiotics. You can tell them, make sure, that when you visit hospital, you're on admission, buy your drugs in the hospital pharmacy. That's another thing you can tell them. You can advise that when you go to the hospital, the doctor tells you, please tell, the doctor tells you, you need to do a laboratory test. Don't say you don't have money. Prioritize your health. Because the truth of the matter really is that in Nigeria, I'm sure we will all agree, we all know, that before a patient comes to you in the hospital, he has gone to the pharmacy or a nearby chemist by himself. Before going to the chemist, he has visited the laboratory and they have told him, that he has malaria and typhoid. And these are quacks, that take advantage, of the ignorant. So you can tell them, to embrace a more positive health-seeking behavior. Those are little things that we can do. Too. And also, we in the last couple of years, we have joined the rest of the world in commemorating the World the World AMR Awareness Week. That is what we are doing right now. It is the reason we are here. So that everybody gets to know more, about AMR.
Thank you so much, Ma. So education is an effective way to reduce antibiotic misuse. Okay, so we have other questions here, Ma. Um, okay, it says, thank you for the incisive lecture. I have three questions. Please buttress a bit on the use of alternatives to antibiotics, such as probiotics. 2, antimicrobial cycling. 3, do you subscribe to point of care testing in the community pharmacy?
Okay, certainly. Point of care testing in community pharmacy, such as what? Can you give examples?
Such
Of
as,
point of care testing. No, let me elaborate.
okay.
I know that one point of care testing is rapid testing for malaria. Yes, if that is available in a pharmacy, that can be done, because really the average Nigerian, knows when he has malaria. In many cases, they know, in fact, they know so much, that even when they are stressed, they attribute it to malaria. And we know that in our environment, there's a lot of falsification. As long as that pharmacy is empowered, with a standard and a proper kit, a test kit. Yes, that can be a way, to ensure, that the person does not take antimalarials without abusing the antimalarial. So if, for example, the pharmacy conducts malaria tests with rapid diagnostic kits and it is negative, the next thing is that the person should go to the hospital. But if it is positive, the person can use antimalarial. Yes, why not? But I don't know about other point of care testing, that we want to do apart from rapid diagnostic testing for malaria. Really, because these point of care tests are available. There are many, there's a number of them. Some of them are quite expensive. We have the biomarkers, the use of biomarkers. We have molecular test kits, that are available only in the hospitals. Biomarkers, should be interpreted only by the doctor attending to the patient, because other clinical parameters of the patient will also be considered. So yes, to an extent, maybe to an extent, point of care tests should be used in the pharmacy, but we need to have a protocol for that, and we need to be sure that we are not abusing it. And then antimicrobial cycling. Antimicrobial cycling, is a procedure, in which classes of antibiotics are prescribed in cycles in a hospital or in a ward. It has been done in some intensive care unit. It's not something you want to do in the community, because in the intensive care unit, they use a lot of antibiotics, and there are endemic strains of resistant antibiotics. And we know that bacteria lose genes, resistance genes, when they're not used for a while. So if we say for 6 months, we are using fluoroquinolones, it's just an example. We don't prescribe outside fluoroquinolones. We do this for 6 months. We expect, that the resident flora, will develop resistance genes to fluoroquinolones. And then after 6 months, we stop prescribing fluoroquinolones. We decide to use only cephalosporins. And after 6 months of that, we decide to use only penicillins and maybe with aminoglycosides. So we assume, that, or we work, with the fact that once we are not, we can return, maybe after a while, to the first one that we started with, fluoroquinolones, because we know that our resident flora would have lost resistance genes with it. So we use antimicrobials in cycles like that. But the challenge here really is that we do not have enough documentation, that this actually worked, but there are some publications, that it has worked in some intensive care units. Now, alternate probiotics. That is another topic entirely. There are some good flora, good bacteria. For example, we have gut flora. We have vaginal flora, and like lactobacillus, for example. And we know that what's the name of this? That promotes. There are probiotics. Probiotics. Promotes. Lactobacilli. They will enable us to retain the normal flora. That will work for us. In other words, we eliminate pathogenic bacteria, because the normal flora are already there. We know that the normal flora, serve a function because they are occupying our gut, for example. They are there first. So the place is already colonized, by the good bacteria. And so there's no space, for the pathogenic bacteria to land. And such probiotics will promote, the occupation of systems, by the good flora. I do not have experience, to talk a lot, about probiotics. So I would recommend, that you read more. On that, but that really is the principle. I hope I have answered that.
Yes, ma'am. Thank you so much, ma, for the answer to the questions. Okay, we have about we have a few more questions here.
Okay.
This person is saying that he believes resistance is as a result of misuse of the antibiotics or using it for the wrong purposes. So in the case where one is resistant to the highest antibiotics or antimicrobial, what's the solution to that case?
I think that this question is too general. It is too general. I think you will help, by giving me a specific example. Because I don't know which and it may help. You may help, by introducing yourself and tell me where you practice, so that I will actually know how to answer the question.
Okay, you then see Chukwu Luka, kindly resend your question so that Pro can do justice to it. So I have
Yes.
another question here.
Yeah, but let me say this, that what I think we should emphasize here is actually use of antibiotic guidelines, use of antibiotic policy. If you have, okay, what should a guideline look like? If I'm to talk, based on our own guidelines in our hospital, we have a list of all, the possible infections that we treat. We have the list. And for every infection, we write, as a hospital, the antibiotic we want to use. The antibiotic, and this is based on the possible organisms that can cause that infection. We will decide on which antibiotic we want to use in case of a child, in case of a pregnant woman, in case of a neonate, in case there is a resistance based on our experience. We decide on the first line antibiotics, the second line antibiotics, and we do that for every possible infection. And so if one antibiotic is not working, or you assume that that one will not work, you go to your second choice of antibiotics. So we consider specifics, for scenarios. There are so many infections and there's so many antibiotics, and there's the fact that the patient you are dealing with, that you think is having an infection and you have given all sorts of antibiotics, may not even have an antibiotic, may not even have an infection. And I have come across so many cases. Let me share one case, one experience with you. This was a few years, some years ago, when I was a resident doctor. From time to time, we'll be invited, to the wards, that they have used all sorts of antibiotics. This patient, is still having fever and all that. And I went there. I would go there and I would say, okay, stop all antibiotics. Stop all antibiotics, allow whatever organism is causing that infection to grow back. And then we'll collect the appropriate specimen and do microscopic culture and sensitivity in the lab. And in all of the cases, oh no, let me not because there was some I wasn't called for. In most of the cases, you find out that by the time you tell them to stop the antibiotic and they stop, while they are waiting for the organism to grow back, the temperature goes down, the fever stops, meaning that the fever was induced by those drugs in the first place. So what I'm trying to say here is that we should lay a lot of emphasis on investigation, on appropriate diagnosis, and not just that we're just looking for antibiotics to use. In looking for antibiotics to use, we just we lose sight, of what is important, the appropriate diagnosis. Recently, I was invited, to look at another a colleague shared a story with me, a pediatrician. This child, about 6 years old, they were admitting, periodically for fever. No matter what they did, the fever will not subside until they found out, that the patient has a tumor. So that was wrong diagnosis. There was another one, the child, that, they are still investigating. This child will have fever, high fever, which will subside after a while. This child, that what is having fever is usually plays around, goes around, plays and all that. They admitted several times, but they were forced to discharge, because they couldn't find any infection in the patient, and so they are still investigating. So what I'm trying to say here, and what I'm saying, rephrase your question, is that your emphasis may actually be on diagnosis, appropriate investigations, rather than antibiotics, or going to look at the highest antibiotic, or where the patient, one is resistant to the highest antibiotic. More often than not, that's not what you need. What you need is correct diagnosis. Fever can be caused by tumors, can be caused by all sorts of things. So you just need to look at the patient again. Thank you. Hello. Can you still hear me?
Yes, ma, we can hear you. Thank you very much, ma. Thank you
The
so much.
next, the next
Okay, the
question.
last question for today. Okay, someone wants to know if it's possible to initiate antibiotic stewardship programs in community pharmacy practice.
You need to define your stewardship program in line with your practice. You need to decide what your needs are. The first the initial antimicrobial stewardship program, was for hospitals. And then we decided, because there was a lot of requests for this, that it should be initiated in the community as well, and then because of that, we developed global point prevalence, for the community, which meant, that we went to clinics, emergencies, and at this point, we wanted to include community pharmacy, and we found out, that the tool was not available for community practice, because stewardship program actually means, that somebody has prescribed an antibiotic for the patient, and you want to be sure, that that prescription, was done appropriately. In the community, in the pharmacy, what you're looking at is, what you do there is dispensing. You dispense antibiotics. You do not prescribe. At the same time, and then what we also found out at that time is that many patients come to the pharmacy without prescription. In fact, over 95% of the patients that go to the pharmacies to buy antibiotics do not go there. I go there without prescription. And so what I can advise for the pharmacy is that you decide, as professionals, how you want to handle that. Do you want to continue attending to patients who want to buy antibiotics without prescription? Or what are you going to do about it, especially? I think that's a huge topic, that cannot be dealt with here.
Okay, thank you so much, ma. Thank you so much.
Hello,
Okay.
I find this question interesting. Sorry, it's like you're not taking all the questions again. When one has become resistant to all antibiotics in the sensitivity list, what can be done when the patient is critically ill as a result of microbial infection? I have had a few experiences in this area. Most of the time, by the time a patient will receive a specimen in the laboratory and the organism is resistant to all antibiotics, that organism is not a pathogen, it's a contaminant. The way you collect specimens matter. the way you do your sensitivity matter, it has to be done with people who know how to do it. There was a day somebody sent in a urine specimen, and we found out, that it was collected from the catheter bag. And there were many bacteria there, which were resistant to all, and they were not inside the patients. They were contaminants, they were colonizers. By the time a patient, an organism is resistant to all antibiotics on the sensitivity disc, one of the actions you need to take is whether the specimen was properly collected or not. Hello.
Okay, ma. Thank you so much. We appreciate
Sorry, I
your.
found another one. I find another one that I found interesting. It's also available for typhoid kits. Do you mean rapid diagnostic tests? Rapid diagnostic tests available for a typhoid kit. I think those using that typhoid kit should be arrested. It's likely to be a criminal activity. I'm sorry if I'm wrong. Because a patient, that has typhoid is not likely to walk up to you to the pharmacy telling you he has typhoid. The patient that has typhoid is usually critically ill. The wider test or the typhoid test, that is authentic, is a tube agglutination test that cannot be available to you as a kit. There is a lot of abuse in diagnosing typhoid. And for your pharmacy, I would advise against using typhoid kits, to make diagnosis.
Okay, ma. All right. So I would invite Chris to take on the next session of the meeting. Thank you very much, ma. Chris, over to you.
All right. Sorry, just a minute. All right. Thank you very much, Ma.